John Weigelt, your coordinating editor for CSAP 17 Audio Companion. And I'm sitting here today with Dr. Shana Showalter, one of our new CSAP 17 authors, to speak with me today. Shana, can you share with our audience where you are located, your primary focus of your clinical practice, and maybe a little bit about how you spend your usual day or week, whichever one is easier, assuming you may have one of those?
Sure, thank you. So I am an associate professor of surgery at the University of Virginia. I am the chief of breast surgery here and the co-director of the Breast Center. My clinical practice is focused primarily on the management of breast cancer, but I also do see benign and high-risk patients as well. My typical week is probably impossible to describe, but I do spend about 20% of my time protected doing research, and then I have a busy clinical practice, and then, of course, the administrative duties with running the breast center.
Well, thank you for that. I know I've asked you to spend some time with me today discussing a number of topics from the breast category of CSAP 17. We're going to review a number of benign and malignant breast topics, and I'm going to lean on your background and your expertise in our discussion. So I'm really interested in getting your ideas about these topics and how you might manage many of them and how you can tell our audience how to manage them. So I'm really looking for you to help our audience understand the topic a little better based upon your expertise. So that's my plan, and let's get started. I would like to begin today discussing breast abscess problems. First, confirming a diagnosis, and my question really is about ultrasound use in a patient who has a breast mass that's tender. Any hints about performing an ultrasound in these cases so that you get a reasonably good exam in a patient who has a painful lesion?
Yes, so breast abscesses are a difficult clinical situation because they can tend to be a chronic problem for patients and are typically not too challenging to diagnose. The clinical exam is very helpful. The breast will also oftentimes appear erythematous and be tender. Patients will sometimes report a fever. And then imaging is also very helpful. So either doing the imaging oneself or having a breast specialized radiologist perform imaging, which is very important. But an abscess has very characteristic findings. Of course, our biggest concern is not missing a diagnosis of inflammatory breast cancer, but with the correct clinical scenario and imaging, we are typically able to pretty easily diagnose a patient with a breast abscess.
And when you say they have typical ultrasound findings, what are those?
If there is an actual abscess, the radiologists are able to see a defined area in the breast, and they are able to see some fluctuation or the presence of purulent material, which is very different from cystic material or a solid mass.
Okay. And what about septations? If they see septations, or can they see septations in a breast abscess?
So yes, they can see septations in an abscess just like you can in a breast cyst, but those two things are usually pretty easy to distinguish between.
We're going to talk about treatment a little bit later, but let me just ask you now, if you see septations, does that alter your initial management at all?
No, it does not alter the management if we see septations.
Okay. Let's talk about non-lactational breast abscesses. Are there specific risk factors that you can identify in a patient with one of these?
Yes, for sure. So probably the biggest one is smoking. You rarely see a patient with a breast abscess that is not a smoker. So smoking, high BMI, and diabetes are all risk factors for developing a breast abscess in a non-lactating patient.
And is there a location that is more common in a non-lactational breast abscess?
Oftentimes we see these in the periareolar region, so either immediately medial or lateral to the areola or right beneath the nipple areolar complex.
Are these also associated with a high recurrence rate?
Yes. So unfortunately, in this population, once they develop an abscess, I oftentimes counsel patients that they are at an increased risk of developing them, most often in the same area, but an increased risk of abscesses in both breasts. These abscesses are usually fairly painful, having them, and then whatever treatment is undertaken. And so I'll sometimes use that as an impetus to try to push the patients to at least consider stopping smoking.
I just got to ask the question because I'm sure it's on everybody's mind right now. How successful are you in getting patients to stop smoking?
That's a great question. And I guess my success rate would be the people that I don't see come back. But I bring it up as many times as I can, but I would probably say my success rate is no higher than anybody else's.
And do these patients sometimes have a fistula associated with these abscesses?
Yeah, so patients that have a abscess or any sort of mastitis can develop a fistula. It's not always present. They can develop fistulas that can become a chronic problem.
Now let's talk about the lactational breast abscess. And one of the questions that always comes up is this really more likely a mastitis rather than an abscess? And it's just a neglected mastitis that produces the abscess?
Yeah, so that lactational mastitis and abscesses are another difficult problem. And the breast exam, as you can imagine, in a patient that's immediately postpartum or is continuing to breastfeed can be very challenging because of the changes in the breast and the changes in the breast prior to breastfeeding. And so that can pose a challenge. Mastitis versus a distinct abscess are typically pretty easy to distinguish between. Is a abscess a result of a neglected mastitis? I would say not necessarily. We do see patients frequently that present just with the pretty rapid onset of a distinct abscess versus patients that present with generalized mastitis.
Okay. A favorite question in CSAP 17 in many of the committees this time was what to tell the mother about continuing breastfeeding when they have a lactational abscess or mastitis. And so I'll just ask you, yes or no?
Yes, for sure. So patients are concerned about effect of the mastitis on the milk, and so they're concerned about breastfeeding in that sense or effect of it making the mastitis worse. But actually breastfeeding and decreasing the pressure in the breast is always recommended in patients that are dealing with lactational mastitis.
What about treatment of these breast abscesses? So when I came through a long time ago, it was breast abscess meant a trip to the operating room, and that has changed to aspiration. But the question I have is, how many times do you aspirate a breast abscess before you consider that approach a failure?
Yep. So great. So yes, most times we try to start with a non-operative approach to the treatment of breast abscesses, mainly because when you do take a patient to the operating room to open and drain and wash out an abscess, we typically will leave that incision open with packing, and obviously that can be a challenge to take care of, painful for the patient. And so we really largely have moved to treating the breast abscess with percutaneous aspiration. The answer to how many times does it take, we do always counsel the patients that oftentimes it will require more than one aspiration. But again, we try to stick with that approach prior to moving to the operating room. A lot of the knowing when to stop and when to move to the operating room comes from the experience during the aspiration. If the radiologists are doing the aspiration under ultrasound guidance and they see collections and are just not able to drain them, that would be one reason that we realize that the approach is failing. And then oftentimes some of it is just pretty obvious based off of clinical exam. When these abscesses are very superficial and you see that very thin erythematous skin, those patients sometimes warrant a trip to the operating room to do the standard old-fashioned incision and drainage.
Do you ever use a drain after percutaneous drainage?
Yep, so great question. So very infrequently, but we will sometimes leave a drain in place, especially if the abscess is deeper into the breast. But now with percutaneous aspiration, the frequency of that has decreased. Oftentimes, because the incision used is large, the surgeon can place some interrupted nylon sutures, not to close the entire incision because you still want to be able to place packing in there, but just to increase the speed at which that incision will close. But for those superficial abscesses that you're going to continue packing, a drain is typically not necessary.
Do you ever see a small abscess that you just decide to treat with antibiotics alone without aspiration as a first attempt?
Yeah, so sometimes patients will come to see us after that has been the first attempt, and for a lot of patients, actually, that approach will work. So if they fortunately have an abscess that is not significantly tender or causing them a decrease in quality of life just because of the location, a round of antibiotics can work, but I will counsel the patients that they are at a higher risk of recurrence of the abscess or of symptoms. And if it increases in size, then we will move to percutaneous aspiration as a next step.
And is the bacteria that you're usually worried about still staph? Is that the most common?
Yes, it is the most common with breast abscesses.
Okay. There were two other questions that some of the CSAP committees got into, which I found interesting, and that the first one was, okay, so we're doing this aspiration now, so how common is an open procedure ever necessary today?
I'm not sure I can put an actual percentage of how common, but I would say it's pretty rare that we are taking somebody to the operating room, although I say that and I did that procedure just last week. So there are times when it's still necessary, but if the surgeon is capable and comfortable or working with very good, breast radiologists, we are really getting away with rarely needing a trip to the operating room for a breast abscess.
Okay. The other question was, the literature talks about a persistent drainage, especially after an open drainage of a lactational abscess with something called a milk fistula. Is that something that is, well, obviously since you're not doing open procedures, not very common, but have you seen something like that?
Yes, I have, and it can be a huge problem. So especially in a lactating or peripartum patient, we really try to avoid an open incision of an abscess, specifically for what you just mentioned, which is called a milk fistula, meaning that the breast milk is coming out of the incision rather than out of the nipple. And I always tell patients that it's kind of like coming out of the path of least resistance. It can be a very challenging problem to fix and to go away, and so that is really what we're trying to avoid specifically in that patient population, which is why we try a more conservative approach to the management of these breast abscesses.
And the treatment of that is just to wait and see until the patient stops lactating?
With the milk fistula?
Yeah.
Yes, so we'll oftentimes recommend packing it, pressure, and then continuing. They actually can continue to breastfeed, and that eventually the problem goes away, but it can be a somewhat chronic and obviously very frustrating problem for a patient who's a new mother to deal with.
Patient and physician, I bet.
Correct.
All right, one last question in this area, and that is, we didn't have much discussion about this because everybody said, no, we don't do it anymore. So we used to say tissue biopsy during a breast abscess drainage procedure was necessary. Now that you're aspirating, or even when you open a breast abscess, is tissue biopsy ever done anymore?
It's rarely done, although I will say in one clinical scenario it's still done, and I don't want to open a can of worms to get into this one, but there is an entity called granulomatous mastitis, which is a non-infectious process, which can be very challenging to diagnose. If we have an index of suspicion for granulomatous mastitis, you actually should not find yourself in the operating room because opening and draining those does not help the patient. But when there is a suspicion for granulomatous mastitis, we will either do a core biopsy, or if in the operating room, we will take tissue. But really, other than that situation, taking a biopsy of tissue is hardly ever done.
Very interesting. This is the first CSAP in a while that we have not had a question on granulomatous mastitis. So I got to ask you, how do you suspect it to stop you from aspirating it and getting the core biopsy?
Yep. So typical presentation is seeing those patients, a very frustrated patient who has probably had several INDs in the same area and has a recurrent abscess or multiple fistulas to the skin. And so you just have to have a high index of suspicion for that entity. But if you don't see it a lot, it's a challenge. So they are oftentimes treated as a patient with an infectious process. But having an index of suspicion for it is probably the best way to actually catch it.
And if I remember right, the path shows granulomatous changes. And then I'd ask you, you got a favorite treatment? Because I know there's some discussion about that.
Yeah, there's unfortunately a lot of discussion about it, but typically the first type of treatment is some sort of immunosuppressant. So I will typically refer my patients to a rheumatologist to help with the treatment. They'll either start with methotrexate or steroids, and then we follow the patient with imaging to look for resolution. But it's challenging. It's a long ordeal. I've oftentimes had patients begging for bilateral mastectomies that are dealing with it, but it does get better. But I have found that working in conjunction with rheumatology colleagues makes the treatment and the follow-up easier.
That's a great suggestion. Let's move on to another topic, and that is mastalgia. And first thing I'd like to ask is, we have one question on ectopic breast tissue, which has not appeared in CSAP for a few issues. So the first thing I'd ask is mastalgia, or can mastalgia be associated with ectopic breast tissue?
Yes, for sure. So a lot of patients with ectopic breast tissue, it's most commonly found in the upper outer quadrant or in the axilla of the breast. And so patients will report, just like they are when they come in talking about breast pain, cyclical pain or swelling in that area. And again, it's another thing where if you have an index of suspicion, that is the typical diagnosis in that scenario, is ectopic breast tissue in the axilla or upper outer quadrant of the breast.
So let's just take cyclical mastalgia and ask you, so when you're seeing that patient for the first time, are there important aspects in the history and the type of pain that give you some idea where you're going to go in the management scheme?
Yes, so breast pain is another frustrating diagnosis, again, for both the patient and the physician, because oftentimes we can't help them. I have found that reassurance does a lot, but in terms of standard treatments, it's sometimes a frustrating process. But yeah, so just asking the questions of how frequently the pain comes, if it comes and goes. Obviously, if the pain is related to the menstrual cycle, that's a helpful one that leads us towards that diagnosis of cyclical mastalgia, but that is not always the case, or the patients haven't actually realized that in relation to their own menstrual cycle.
In CSAP 16, we championed tamoxifen as the treatment of choice. And recently, not only in the discussion in CSAP 17 committees, but in the literature, I've been seeing that doesn't seem to be the right answer. How do you feel about that?
Yeah, so I was actually kind of surprised when I was reviewing the questions and answers that the answer to the breast pain question was tamoxifen, because I will say that in my own clinical practice, we rarely get to the point of prescribing honestly any medication for breast pain patients, especially right at that first meeting in time, just because there are side effects to those medications, as we know. I mean, oftentimes it's hard enough to get a breast cancer patient to take tamoxifen, so using it for breast pain has not been my favorite way of proceeding. Again, typically once we have an idea that what the diagnosis is, I will really emphasize the reassurance that the patient doesn't have cancer, and that actually does help quite a bit. And then I will talk to patients about some really basic solutions that can help, making sure that they're wearing a well-fitting bra. So just, especially in patients with large breasts, you want the weight of the breasts off of them, and so a bra that can keep the breasts kind of up and in is what I tell them. And then I oftentimes will say, just like a headache, although we don't talk about our breast pain as much as people talk about headaches, that you can try ibuprofen and Tylenol for the pain before going to something more substantial like tamoxifen.
What about primrose oil?
So there has been clinical data to say that primrose oil, or oftentimes also called evening primrose oil, does not help patients with breast pain. That being said, in that situation where you are, the patients are asking or looking for more than just buying a new bra, I will still mention it as an option to patients just because it's easy to get. You don't need a prescription. It's not going to cause any harm. And a trial of that, whether or not it's a placebo effect, has been successful for some patients.
You're probably thinking right now, what does Dr. Weigelt know about breast pain? And I will tell you that because the tamoxifen was the answer in CSAP 16, I had many questions about that, and so I had to learn something about it so I could write a reasonable response. So how about moving on, and let's get closer to maybe the malignant topics, and let's talk about nipple discharge. So what can you tell our audience that you can learn from the physical exam and the appearance of the discharge?
Yeah, so for nipple discharge, another common symptom that brings patients into our clinic, we really want to distinguish from pathologic versus physiologic discharge. So we focus in and ask questions of the patient that can really help us with that. Number one is whether or not it is unilateral or bilateral. So we are going to be more concerned about unilateral discharge, and then honing in on that even more, we can ask them if it's multiduct or uniduct. A patient might not necessarily be able to answer that question, and that one we can figure out pretty easily on physical exam. We also ask the patient whether or not the nipple discharge is spontaneous or non-spontaneous. So again, we would be more concerned about spontaneous nipple discharge. I would say the most common way a patient explains it is that when they take their bra off at night, they notice either some clear discharge on their bra or bloody discharge. And then we also ask them about the consistency of the discharge, so whether or not it's milky, green, versus clear or bloody. And the clear or bloody, unilateral, uniduct discharge would be the most concerning.
Does the discharge ever get sent for cytology?
There's a tricky topic in regards to sending discharge for cytology and actually for doing hemocult testing on it, which we really have gotten away from doing just because the trauma of getting the discharge we find that oftentimes can be misleading and is actually really not going to change our management. So no, we do not send the nipple discharge for cytology.
And so when you have a suspicious finding based upon your physical exam history and appearance, what's your next step?
Yep, so the next step is typically breast imaging. So if the patient hasn't had breast imaging, we'll start with the basics, which is typically a mammogram, and also followed up by an ultrasound. So a safe test where we can sometimes find the culprit of the discharge. So most commonly we would be looking for a mass that would be associated with the duct and is typically going to be a papilloma. So next step would be mammography and ultrasound as the first initial step in working up a patient with a new nipple discharge.
So there are patients who have a discharge that looks and sounds like there's nothing wrong, and you just follow those patients, or does everybody get some kind of imaging?
So typically if somebody has what we would consider as potentially to have pathologic nipple discharge, we wouldn't stop at just imaging and follow-up. We really do want to figure out what the cause is. If somebody has physiologic discharge, yes, that's a patient that you would feel very comfortable following and not working up further. But with a patient with pathologic nipple discharge, we are going to continue working until we figure out what the problem is, what's causing the nipple discharge.
Okay, so I like that continue working, because in CSAP 15 we had a number of questions going forward, i.e. working more because the imaging was not very diagnostic, and ductoscopy was felt to be helpful. Seems that these questions have disappeared. Is that true in clinical practice too?
Yeah, I would say that is true. I will say of ductoscopy, it's a very user dependent. So there are focuses of places where people are very comfortable with that. They trained with it, and so they'll continue to use it. But it's not something that we're commonly trained on and that we have found to be helpful. So I would say it's even hard to say. But ductoscopy is not a primary method for working up nipple discharge at this time.
So you made the comment that the diagnosis that you're most likely going to encounter is an intraductal papilloma. So you make that diagnosis. Do you need to do a biopsy, or do you just proceed to excision?
Yeah, so the only way you would diagnose a papilloma is from the results of the biopsy. So if imaging shows something, a mass, then the next step would be a core biopsy, and that is the way to diagnose a papilloma. So even if something looks like a papilloma, we wouldn't leave it at that and would typically proceed with a core biopsy. A papilloma is something that the pathologist will report on, and then typically what you're looking for is words that say either atypia is present or not present to help guide the recommendations as to whether or not a surgical excision should be the next step.
So if atypia is not present, but the nipple discharge continues, do you excise the papilloma then?
Yes. So typically, after we get a diagnosis of papilloma, we'll have a patient meet with the surgeons to talk about the options. And even patients with a papilloma without atypia, it's really not unreasonable to proceed with an excision, knowing that the risk of upgrade to a malignancy is much lower than it would be if there was atypia present. Patients oftentimes want the nipple discharge to stop, and so excising the papilloma will certainly do that. And we always feel much more comfortable doing a directed excision of a known papilloma than doing just a kind of blinded, what we call a central duct excision, which is removing all the duct tissue right behind the areola. So if you're lucky enough to be able to find a specific mass that is then biopsied, proven to be a papilloma, surgical excision is a very reasonable next step.
And when you talk about directed, you're talking about following the duct down until you find the papilloma, and that's the excision that you're doing?
Sometimes, yes, but oftentimes once it's biopsied, we'll have the radiologist actually localize that because it can be far enough back that you wouldn't want to make a circumareolar incision. So if we have a biopsy-proven papilloma, at least here, we use radioactive seeds for localization. So I would most likely, unless it was right behind the nipple, proceed with a localized excision of that papilloma.
And if you have atypia, how do you handle that?
Yeah, so if we have atypia, I would more strongly recommend an excision because at that time we have a higher concern for upgrade to malignancy. So we'll counsel the patient that a papilloma with atypia, final pathology after surgery, has a risk of coming back with DCIS most commonly or potentially invasive breast cancer.
Let's talk about breast masses, and let's talk about the ultrasound diagnosis. And can you give us a quick primer on the difference between a benign mass and a malignant mass, or what we should recognize?
Yeah, so the real basics in terms of diagnosing a benign versus malignant mass, let's say we're talking about something like a fibroadenoma, which is a benign mass, then you'll notice on ultrasound is a great way to differentiate between benign and malignant masses. And the benign mass will typically be larger in the transverse direction, and we'll have what we call a homogeneous echo texture. And then pretty oftentimes you can actually see a thin capsule, so you can see that it's very distinct from a breast cancer, which is more likely to actually look like it's invading into the breast tissue rather than being a distinct separate lesion.
I know it was beaten into my head by most of the CSAP committees that ultrasound is your first step in looking at a breast mass in a patient who comes to you complaining of a breast mass. So if you get the ultrasound, does everybody then get a mammogram?
Yeah, so that's a great question. So I would say ultrasound, what you were saying was beaten into you, that ultrasound is the way to start, but it really depends on the age of the patient. So if a patient is less than 40 years old, they have a breast mass that is not outright concerning on clinical exam for malignancy, which is rare in that patient population, then we would start with ultrasound. If a patient is over 40, we would start with a mammogram and an ultrasound. So somebody who is over 40 with a breast mass would have both imaging modalities.
And if you find a mass, is there an age cutoff for when you proceed to any kind of biopsy or not?
Not necessarily. So the biopsy decision at that point is really based off of how the mass appears on imaging and whether or not you are comfortable calling it benign versus something that's more concerning. So as an example, a simple cyst on a 20-year-old versus on a 60-year-old really wouldn't be managed any differently if it meets the criteria of looking like a benign cyst.
In that younger patient who the ultrasound looks like a fibroadenoma, they're ones that you follow with reassurance again?
Yeah, so with a fibroadenoma, if you are comfortable with the imaging findings and it fits the criteria to be a benign fibroadenoma, there's a couple ways to proceed. If the patient starts in radiology, oftentimes they will be given a BI-RADS 3, and the radiologist will follow that lesion every 6 months, typically for 2 years. Sometimes we'll see those patients and they've already had a core biopsy, so they'll come with a diagnosis of a fibroadenoma. And as long as the clinical exam is consistent with a benign lesion, just quickly would be a mobile, palpable mass that the patient says has been there for a long time, hasn't had a high growth rate or any growth rate at all, that core biopsy and imaging consistent with a benign mass. Those are patients that we would follow, again, provide reassurance. And really, we wouldn't do much unless the mass is causing pain, or in some patients that are thin with a large fibroadenoma, it can sometimes be a cosmetic concern, and then that would be another indication for excision.
So listening to you describe that approach, how many women today with a breast mass that looks like a fibroadenoma really do get a biopsy instead of just being followed with imaging?
I think it really depends on where they start with their imaging. So at places where the radiologists are very confident with their imaging techniques, I would say the biopsy rate is much lower. We oftentimes get referred patients from the outside that have already come into us with a biopsy. But I would say the most common way that these patients are managed is with serial imaging, again, every 6 months for about 2 years, and a biopsy typically not necessary.
Now, you mentioned BI-RADS, and for those of us who don't do this on a daily basis, can you review the BI-RADS classification system for us?
Yeah, so BI-RADS classification is a classification used by radiologists in order to help define what they are thinking about a specific breast lesion. So it goes between 0 and 6. A BI-RADS 0 means that the radiologists have seen something, but they're not happy with the imaging and they need to do more imaging. So it doesn't mean anything good or bad. Oftentimes when we're seeing patients for a second opinion with imaging from another institution, we will look at their imaging and call it a BI-RADS 0 just because we weren't happy with the quality of the imaging. A BI-RADS 1 signifies that there's no significant abnormality and nothing was found. So best case scenario, after a screening mammogram, a woman would get a report that her mammogram was BI-RADS 1. BI-RADS 2 is a benign finding that they see, so there's something there that they see, but it's benign and that no further action is going to be taken. That's different than a BI-RADS 3. A BI-RADS 3, again, you're seeing something, and they call it probably benign, and so most likely the action taken after BI-RADS 3 is short-term follow-up. So there the radiologists have basically a better than 95-98% likelihood that this lesion is going to be benign, but they will recommend short-term follow-up. BI-RADS 4 is when the radiologists are going to recommend some sort of biopsy. So there's something suspicious that is found that warrants a biopsy. BI-RADS 5 means that we think that there's a greater or at least a 95% chance that whatever it is that we're seeing is actually a malignancy. So again, a biopsy is going to be recommended. And then a BI-RADS 6 is when you already have a biopsy-proven cancer and you're reporting on it. So a BI-RADS 6 means a known malignancy in the breast.
Now, the other thing we talked a lot about with the BI-RADS or all imaging results is the concordance with biopsy results. Can you explain this word concordance and how it impacts your clinical judgment?
Yeah, so this is a very important part of the whole process, and it really helps when there's a multidisciplinary approach to this process, meaning that the breast imagers, the pathologists, and the surgeons are all working together. So when an abnormality is seen on a mammogram and a biopsy is performed and then the pathology comes back, what you want to determine is that pathology result concordant, meaning does it explain the finding? So for example, if you biopsy a mass and the pathology report comes back as benign breast tissue, we would call that a benign discordant biopsy and either recommend a repeat biopsy or surgical excision because we didn't answer the clinical question. Whereas if we biopsy, let's say, new calcification seen on a mammogram and the pathology report comes back as fibrocystic changes associated with calcifications, then that would be classified as a concordant biopsy result, meaning we saw something and it explains the imaging finding.
And so you want them to be concordant, not non-concordant.
Correct. So a discordant biopsy means we haven't answered the question, so we need to either do another biopsy or we will sometimes see those patients in a surgical clinic because the radiologist doesn't feel that they're able to be more successful with a second biopsy, and so then we would do a surgical excision really because of a benign discordant pathology result.
Let's talk about some specific lesions, and can you explain to us what they are and what their risk of cancer might be? So let's start with sclerosing adenosis.
So sclerosing adenosis is a pathology result that is seen after a biopsy, and this is a non-malignant lesion, so that's one of the most important things to explain to the patient. Typically, sclerosing adenosis is recommended to have a surgical excision, and again, because we're concerned about an upgrade to malignancy. And so those patients have a low upgrade, but it is something that we do excise.
And is this different than fat necrosis?
Yes, so fat necrosis has a specific imaging findings, and if it is biopsied, again, it will come back as fat necrosis. Fat necrosis is completely benign, does not put the patient at an increased risk of malignancy, and is not typically excised unless, again, it is causing the patient discomfort or some sort of cosmetic concern.
And how about PASH, P-A-S-H?
Yep, so PASH is completely benign again and is one that is not typically recommended for excision and does not put a patient at an increased risk of breast cancer. So a biopsy result of PASH does not warrant any sort of high-risk screening or follow-up or surgical excision.
Okay, I hope I have these in orders because I think we're going to go closer to malignant risk here soon. So what about ADH?
Yep, so ADH, atypical ductal hyperplasia, are atypical cells. That is one that we will recommend for excision because they do have, I would say, a 10 and 20% upgrade rate to either ductal carcinoma in situ or invasive breast cancer. And then ADH does portend an increased risk of breast cancer on that patient. So for example, if we saw a patient with a core biopsy of ADH and did a surgical excision and came back with just more ADH, so fortunately not malignancy, we would then talk to that patient about their increased risk of breast cancer.
And would treatment be offered at that time to reduce the risk?
We would have a discussion. Typically with the high-risk discussion, we talk about increased screening. So there's a couple of computer models that one can use to determine an individual patient's risk to determine if they are actually what we classify as high risk. So typically a high-risk patient is somebody who has a greater than 20% lifetime risk of breast cancer. And so in those patients, a patient with atypical ductal hyperplasia that is deemed to be high risk, we can talk about increased screening, so adding potentially a MRI or a screening ultrasound to their annual mammogram. And then we will also talk to them about chemo prevention, tamoxifen or raloxifene, to help decrease the risk of breast cancer. It is challenging, I would say, anecdotally, to get patients to actually take those medications, but it is something that is definitely warranted to discuss with them.
And if you find ADH in one breast, does that affect the risk of cancer in the other breast?
Yes, so ADH is one of those high-risk lesions that will put a patient at increased risk of bilateral breast cancer.
Now what about ALH?
So ALH, atypical lobular hyperplasia, is another high-risk lesion. So at the end of it, we do talk to those patients at having an increased risk of breast cancer. So ALH and LCIS, so lobular carcinoma in situ, are a little bit different than ADH because there are very specific certain situations where we actually will not recommend an excisional biopsy of those lesions.
And no chemo prevention either?
Those patients would warrant. So, sorry if I didn't make that clear. So somebody with ALH or LCIS would still warrant the discussion about being high risk in consideration of chemo prevention.
Now, at the general surgery review course, I sat through the breast cancer lecture, and they talked about LCIS, and they talked about classic and pleomorphic LCIS, and went out of their way to make a statement that these are different. Can you help me understand that?
Yeah, so pleomorphic LCIS is a challenge in terms of diagnosing, and really is always a topic of conversation as to what to do with it versus classic LCIS. So when we are seeing the terms pleomorphic LCIS, it raises a bit more of a red flag that there could be associated invasive component to that. And so we'll potentially treat those differently up front. Both would warrant an excisional biopsy in some circumstances. Most surgeons will try more so than with a typical excisional biopsy if somebody has pleomorphic LCIS to truly remove all of the lesion to negative margins. And then pleomorphic LCIS can also be a topic of conversation when it is seen on the margins of a lumpectomy that is actually done for cancer. So they're different, and it can definitely be confusing, but the classic high-risk lesion that we talk about is LCIS, and then pleomorphic LCIS just adds a bit of complexity to the conversation.
So the pleomorphic is more likely to undergo excision. Is that a fair statement?
I would say so. This part can be a bit challenging. Right now, the recommendations for ALH and LCIH in terms of excision, we will excise those when they are associated with the imaging findings. I'll explain that a little further. If calcifications are seen, a biopsy is done, and the results show LCIS associated with those calcifications, we will recommend excision of that lesion. However, If calcifications are seen and a biopsy is done and the results come back, let's say, with fibrocystic changes that are associated with the calcifications, and LCIS is incidental, meaning it didn't cause the imaging finding, we will not typically recommend excision at that time. However, the fact that the patient has LCIS still puts them in the high-risk category. So they still warrant the high-risk discussion, but not necessarily the surgery.
So if you have the biopsy that shows classic LCIS, then you observe?
If that LCIS was incidental, meaning not associated with the imaging finding.
So we're excising that pleomorphic LCIS. You find it in your specimen. And what margins do you need around that lesion?
Yep. So again, not a very well-defined answer, but different than an excisional biopsy for any of the other high-risk lesions. We typically try to obtain negative margins, so no evidence of pleomorphic LCIS on ink. In the same, when pleomorphic LCIS is at the margins of a cancer specimen, that will warrant a re-excision to negative margins, whereas LCIS would not. We wouldn't necessarily do a large disfiguring kind of cancer operation for somebody with an initial diagnosis of pleomorphic LCIS, but the effort is definitely made to remove the entire lesion, which is kind of a different approach for some of these other high-risk lesions.
So how about a phylloides tumor? When do you suspect this?
Yeah, so phylloides tumors, we suspect when a patient reports from their story a rapidly growing mass. So exam consistent potentially with similar to a fibroadenoma, but the story is usually a little differently, that the patient notices that the mass increases in size, or in that scenario where a patient was deemed to have what was thought to be a fibroadenoma, and on their 6-month follow-up imaging, it's noted to have increased in size. That's when we will be suspicious for a phylloides tumor.
And diagnosis is made by mammogram or biopsy?
That's a challenging one. So diagnosis, not necessarily made by mammogram because they can very much mimic a fibroadenoma. And biopsy can sometimes diagnose these lesions, but they tend to have very heterogeneous pathology. So if you have somebody with a high clinical suspicion of a phylloides tumor, but the core biopsy reveals fibroadenoma, that lesion still warrants excision and oftentimes will be found to be a phylloides tumor once the pathologist is able to look at the entire mass.
And when you excise these tumors, what's the margins?
Yeah, so that's a great question. So if one knows what the diagnosis is at the time of the surgery, then the goal is to have at least a 1 centimeter margin around the mass. If a mass is kind of shelled out, which they oftentimes will be because they're not invading the breast tissue like a typical invasive breast cancer, and then is found to be a phylloides tumor on pathology, we would definitely recommend going back in order to obtain those wider margins.
Is there adjuvant therapy for these tumors or not?
Yeah, so this is another one which really all of the recommendations are based more off of large case series than any good clinical trial data. The adjuvant management is oftentimes dictated by the grade of the phylloides tumor and the size, but there are times when we would treat these patients with chemotherapy or radiation therapy. The biggest concern is a risk of local recurrence and also a risk of distant recurrence. But we also oftentimes talk about keeping radiation kind of in our back pocket so that if the lesion does recur, we have something to use at that time. So it's typically when we're talking about a patient that has a large phylloides, it's a back and forth discussion, and there's not a correct textbook answer as to the utilization of adjuvant therapies.
And is it chemo or radiation therapy that's most commonly used?
Both are considered, but most commonly for local control would be radiation therapy, but there are times that both are considered.
Let's move on to another topic, and that is male gynecomastia. And very interesting, we did not have a question on it this time in CSAP 17. So can I ask you, when you see a patient with male gynecomastia and it's not an adolescent, where do you start with your workup?
Yep, so if the patient's not an adolescent, if they have bilateral gynecomastia, there's actually not much of a workup that needs to be done. So in terms of if we were considering potentially talking about imaging, if bilateral gynecomastia is a clinical diagnosis and the workup is kind of complete at that point.
So you don't use mammography in most of these patients?
No, so a male patient will warrant mammography if we have, or the patient has concern for a distinct mass or abnormality, specifically if it's unilateral.
Well, then that leads me to the male breast cancer question, which is also missing this year from CSAP 17. So are we still sure it's not really worse than when breast cancer appears in a woman?
Yeah, so stage for stage, male breast cancer is not worse when it appears in a woman. Where that kind of fact comes from is just the fact that male breast cancer typically presents at higher stages than it does in women. Men are not getting screening. There could be some social factors that prevent them from getting clinical evaluations of a concerning mass or physical exam finding.
And once you see a patient with a unilateral breast mass, the workup is essentially the same as if you were dealing with a woman?
Yes, so the workup is the same in terms of imaging and proceeding with a image-guided biopsy.
Okay, I have another question here about our M&M conferences. I often hear a case that's presented of male breast cancer, but I never hear anybody talk about biopsy results that show high-risk lesions in a male. So my question is, all those high-risk lesions we talked about, do they occur in males?
Those high-risk lesions are most often found because they're screening detected, and men are not getting screening. So those high-risk lesions and all of the data that we have about upgrade and risk of future breast cancer is all in female patient populations.
So it's just because screening is not used that we don't talk about them and they possibly could be there?
Yep.
Okay. Shana, I really appreciate you talking about all these issues with me today. I really enjoyed this. I see our time is about up. I really want to thank you for being a new CSAP author as well. And as such, I'd ask you, do you have any thoughts about our process as well as the fact that this is your first interview on CSAP Audio Companion? So the stage is yours to tell us whatever you think.
To answer your question, I thought, as being a new author, the process was interesting and it was a great experience. And I'm very thankful that I was given this opportunity. I particularly enjoyed the portion where we were meeting face-to-face and discussing with experts in the field the different questions and critiques that people had written. Obviously, I struggled more so on writing questions that were not in my area of expertise, but it was a challenging process and definitely learned a significant amount about being able to write good multiple choice questions.
Well, you also did a great interview, let's put it that way. So
thank you. Not as comfortable, but thank you.
You did fine. So, all right. Well, once again, Shana, I thank you very much for your contributions to CSAP, and you have a nice rest of the day. Thank you.
Thank you.
That's the end of this session for this category of the CSAP 17 Audio Companion. This category will continue in the next session.